So, thank you for joining us today. We are here with Dr. Visa. Thank you so much for joining us. And we are the ADRC, the Alzheimer's and Dementia Resource Center here. We have been in Central Florida for more than 40 years. And we are a nonprofit organization providing help support to caregivers. We have support groups. We manage the state of Florida Brain Bank. We have a resource room where people can come and get books free of charge. But today, mostly we are joined by the director of the Memory Disorder Clinic at Health First. It's Dr. Visa, and we are very honored to have you today joining us. Dr. Visa completed her medical school training at Kilpatrick Medical College in India and her postgraduate training in the United Kingdom. She completed her residency in internal medicine and then geriatric fellowship at Cleveland Clinic Health System in Cleveland, Ohio. She is board certified in internal medicine and geriatrics. She is also the medical director at the East Central Florida Memory Disorder Clinic.
Thanks, everyone, for joining me this morning. We're going to talk for the next 45 minutes about next steps after a diagnosis of dementia. So today, the overview of the talk is what does somebody do after a diagnosis of dementia is made for their loved one or for yourself. It can be very overwhelming, and sometimes it's good to have a plan so that we know exactly what the goal is. And today we're going to outline what that plan should be like. So the first one is assemble your own healthcare team. Learn and educate yourself about the kind of dementia that the loved one has, the different kinds of dementia, and how to plan for the future. This includes legal planning, financial planning, and then most people want to stay in their own home. The goal is for people to stay in their own home for as long as it's safe and to have as much autonomy as long as they are safe. So we'll talk a little bit about safety and independence and what kinds of things do they have in control to modify the progression of the dementia. So we're going to talk about lifestyle modification. I'm going to focus quite a bit on caregiver education because a lot falls on the caregiver support. The caregiver should not feel alone in their journey, and what are the different resources available to support the caregiver and the person with dementia. So first, let's talk about, memory, normal aging, and memory loss. A lot of times when I see patients for the first time, they'll usually say that, I'm 85 years old, and sometimes I want to say the name of someone or I want to name something, and the word doesn't come to me right away, but it comes back later. So they always want to know, is what I have normal aging for my age, or is this something I should be worried about? So on the x-axis, we have age, and on the y-axis, the baseline personal cognitive ability. So when you look here, up to the age of 60, 65, it looks like our cognition, we are quite sharp. Most people will say, yeah, I'm pretty sharp. And then they're noticing some changes in their cognition. They're slowing down. So if you look at the green line, that is normal aging. So as we get older, we do have some changes in our cognition, but these changes do not affect how we are functioning, and they are considered normal. So practically speaking, what it means is as we get older, you might find that it takes a longer time to do something, but you can still do it. And this also includes having word finding difficulties. So if you're in a party and you're talking about your latest trip to France, and you say, oh, yeah, and then I went to the museum, and you know what the museum is, you were there, but then the name is not coming to you right away, and you might feel a little embarrassed. Or maybe look to your spouse to see if, your spouse will supply the word. And then you get embarrassed, and then you move on to the next topic, and then the word comes back to you. Oh, the Louvre. So that is normal. It comes back to you. The other change which we can see with normal aging is we are not able to multitask as as well as we did in the past, but we're still able to do the different tasks. So when you look at the blue line, you'll find that the changes in memory are going further down compared to the normal aging, and that is mild cognitive impairment. So in people with mild cognitive impairment, they'll notice that their brain is slowing down, and perhaps their family might notice it as well. They come in for testing, and we notice that when compared to their peers, people with comparable education and age, the cognitive deficits are a little bit more. But these changes are not sufficiently severe enough to interfere with the person's functioning, and that is called mild cognitive impairment. So there's normal memory, and then as you get older, there's normal aging, and then it looks like a slippery slope. So the initial part of the slope is mild cognitive impairment. And then when you look at this graph, you look at the purple line, which goes further down compared to mild cognitive impairment. That is dementia. Because what happens there is it's crossing this dotted horizontal line, which is the line above which the person is able to live independently with their day-to-day activities. And the purple line is crossing the horizontal line and going down vertically below the horizontal dotted line, because here the cognitive deficits are severe enough to interfere with the person's functioning to the point where they are no longer able to do those things and they need the assistance of somebody else. For example, they're getting lost driving, they need somebody to drive them. They are forgetting to pay their bills, forgetting to take their pills, etc. So when the cognitive deficits are interfering with their social functioning, day-to-day functioning, that becomes dementia. So a lot of times people ask, like, what is dementia? So if you want to define dementia, it's the progressive loss of intellectual functioning. And it's not only memory that is affected, it also affects reasoning, processing, judgment, which interferes with day-to-day activities. And often there's also some mood and personality changes resulting from organic disease of the brain. So it's a progressively worsening memory loss, which is affecting day-to-day functioning. So the first step when somebody is given the diagnosis of dementia is to gather information about the dementia. What is the diagnosis? What kind of dementia is it? That's a frequently asked question. Is this Alzheimer's or all Alzheimer's dementias? What's the difference between dementia and Alzheimer's? And we'll talk about that. So find out the type of dementia and then find out what stage of dementia it is. And that's important to know because if somebody is in the mild stage, it's good for the caregiver to learn about what to expect, to know whether the loved one has progressed to the next stage. And the resources and the recommendations for each stage may be different. Do know about the medical comorbidities because those can be addressed. So what do I mean by that? If somebody has vascular dementia, it's important to know that the risk factors are perhaps diabetes, high blood pressure, high cholesterol, and those things need to be controlled in order for us to slow down the progression of dementia. The other common medical comorbidity people don't talk about much and caregivers need to know is sleep apnea. So I always say a good way to remember this is the brain needs two things for normal good memory. The first one is oxygen. And so in people with sleep apnea, if day after day, night after night, there is an obstruction and they don't sleep well and they don't get enough oxygen to the brain, it affects the memory. The good news is it can be treated. So once you treat the sleep apnea, a lot of people function better. Their cognition is better day to day because they are resting well as well. The second thing the brain needs for good memory is sugar. So you want the sugar to be up and down like this, not up and down like that. So in diabetics, that's why when the sugar is very low, hypoglycemia, the brain does not think well. People may even go into a coma or they may shake, they may get seizures. Similarly, if the sugar is very high, people go into a coma. But even in non-diabetics, they have shown in studies in non-diabetic rats that when they feed the rat different kinds of food. The kinds of foods that brings the sugar up slowly and only a little bit and then drops down gently. These kinds of foods, when the rats eat, they are able to figure out the maze and the puzzles much more easily than rats that are fed with highly processed sugars, where the sugar goes up very high and then crashes down. And we may have seen that ourselves, that when we have what we think is a really good meal, right? Like a good pizza, or if you eat pasta, if you're over eating carbs, we feel that way. After eating, your head is drowsy and you don't feel like doing a puzzle or anything. Whereas when you eat good sugars, like natural sugars from fruits or whole grain bread, what we call complex carbohydrates with low glycemic index, the brain seems to function better. So this is a frequently asked question. My dad has dementia. Is it Alzheimer's? What's the difference? So if you think of dementia as an umbrella used to describe a range of symptoms associated with cognitive impairment, under that umbrella, there's different kinds of dementia. The most common type of dementia, by itself, the individual type of dementia, is Alzheimer's. About 2/3 of dementia are Alzheimer's pathology. In other words, all Alzheimer's are dementias, but not all dementias are Alzheimer's, because you can have dementia due to vascular strokes. It's called vascular dementia. You could have dementia due to Parkinson's disease dementia. But if you really look at it today, as people are getting older, the fastest growing population in the United States is 85-year-old and above. So when we do autopsies on patients who are older than 80 years, the most common type of dementia is mixed dementia. So it's not just one kind of dementia, it's more than one kind of dementia. And the most common type is mixed Alzheimer's and vascular. And if you think about it, by the time somebody is above the age of 80, there's a good chance that they've had some vascular risk factor, be it high blood pressure, diabetes, high cholesterol. So when the autopsies are done, there's a lot of vascular changes in the brain. Although, say 10 years ago, they had a neuropsych testing and the pattern looked like Alzheimer's. The ultimate diagnosis is mixed Alzheimer's and vascular. And what's important about this is if somebody has Alzheimer's dementia diagnosis, their chances of having vascular changes on top of it is much higher as the disease progresses if they have vascular risk factors, and vice versa. That is why whatever is good for the heart is good for the brain. So if somebody has Alzheimer's dementia diagnosis and they have high blood pressure or diabetes, it's important that the blood pressure and blood sugar is well controlled to control the progression of the disease. So why are we talking about Alzheimer's? So if you look at Floridians with Alzheimer's dementia, if you look at the number of 65 plus year people who are diagnosed with dementia, in the year 2020, there was about 580,000. And by 2025, there was almost a 25% increase in the number of patients diagnosed with Alzheimer's. And this does not tell the whole story. It's the tip of the iceberg, because we all know that a lot of people with memory loss don't really come to get a diagnosis, because there's a myth that memory loss is a normal part of aging. So many people don't come. And sometimes the family wants them to come and have an assessment, and the patient themselves don't want to come, either because they confuse memory with intelligence and say, I don't want to be told that I'm crazy or I'm losing my marbles, or they worry that family might take them out of their home, stop them from driving. But these numbers tell you that the number of people that are diagnosed is increasing exponentially, especially in Florida, because there's a lot of older people here. For example, I live in Brevard County, where 1 in 4 is above the age of 65, and people are living longer, and Florida is a great place for retirement. So we see a lot of older folks. So when we think of dementia, the most common symptoms that come to our mind are somebody whose short-term memory is not good. Their long-term memory is very good. They remember what happened when they were in their 20s and 30s, but if you ask them, where did they go yesterday for lunch and what did they have, they may not remember. Repetition is very common. They keep asking the same question because they forgot what you told them. Difficulty with problem solving, decision making. They have reduced ability to plan and organize. It's very common for them to get confused easily, especially if the routine is disrupted or if plans are complicated. They have a harder time dealing with complex tasks. Disorientation is very common, and trouble with language, word finding difficulty is common. With Alzheimer's dementia, it's not just cognition, but also changes in mood and personality. Some people may become more apathetic, which means they are no longer interested in things that they used to do before. They may get more irritable, and this might especially be more obvious as the day goes on. It's called sundowning. Some people might get aggressive. They have sleep disturbance, and sometimes they have hallucinations or delusions. The other symptoms that they can have is change in appetite. One good reason for that is if you look at the memory area of the brain, if you divide the brain into two, you have memory area one on each side. It's close to the area of smell. So a lot of people lose their sense of smell even before they lose their memory. And so you might find that whenever we lose our smell, for example, if we have the common cold, the taste sensation also changes. And we don't really want to eat food. Food doesn't taste the same. And that's the same thing that happens in patients with Alzheimer's. So they might not want to eat that much, or they might forget to eat, or they may forget how to put together a meal. Very often, I'll hear my patients' caregivers say, Mom says she's not hungry. She doesn't want to eat. But if we take her out to a restaurant, she completely finishes the plate. Because that'll tell me, like, if somebody was there to make the meal, keep it in front of the loved one and sit with them and give them company and eat, they will eat. But if you just bring everything, put it in the freezer and say, Mom, eat it and come next week to check, they may not have touched it at all. They have difficulty with balance and coordination, and frequent falls are pretty common. So what happens in patients with Alzheimer's? So on the left, you see a healthy brain. It reminds you, it looks like a nice cauliflower full of florets. But on the right side, you can see how much the brain has shrunk or is wasted because it's lost a lot of brain cells. And so when we look at this picture on the MRI brain, we call it atrophy, shrinking of the brain, including the memory area of the brain where new memories first stored and processed. So here's the healthy control on the left. And this is the memory area. You see one here on the left and then one on the right. This is called the hippocampus, where you have new memory, which is being stored and processed. And here you can see how much shrinking there is of the hippocampus, which is the first sign in almost 75 to 80% of Alzheimer's disease patients. So if you think of vascular dementia, what happens here? Here it's caused by damage to the blood vessels in the brain. And so the symptoms can vary depending on the severity and location of the damage. And sometimes in my vascular dementia patients, they may not have had a stroke that they are aware of. But when we look at the brain scan, you'll see a lot of vascular changes in the brain. So here, the memory loss is slightly different. These are not the patients, that tell me that the family will not say, my mom is constantly repeating, telling the same thing over and over. Many times I suspect vascular dementia when I'm talking to the family separately, and they have a hard time telling me what's wrong with the patient's memory. It's very hard to describe. Whereas in Alzheimer's, it's very easy. They'll tell me, Mom cannot remember. Within 5 minutes, she forgets. And she's going on repeating, and she has word finding difficulty. In vascular dementia, what's more difficult to explain is because they have a lot of problem with attention, concentration, organization, executive function, which is planning, organization, dealing with complex tasks. So more often than not, I have to get the history out of the family by asking them everything that includes executive function. For example, the things that day to day we do that include executive, that actually requires executive function, is management of money. So these are the patients who are having difficulty handling their money. They may be impulsive. They may be involved in scams because they have poor judgment. So they are giving away their personal information or to a scammer or to some stranger on the phone. They are notorious, if they are diabetics, to have poor control of diabetes, because the management of diabetes requires a lot of executive function. starting from choosing the right foods for groceries and knowing how to manage complex insulin regimens, knowing what to do when there's low blood sugar. All of this requires a lot of executive function. So a lot of times when the endocrinologist has poorly controlled diabetic, they send the patient to me and we find out that there's actually beginnings of vascular dementia. Patients with diabetes are at a much higher risk for dementia than non-diabetics. Because again, we go back to, I told you, sugar is one of the important things for memory. Vascular dementia patients also have behavioral changes. They have mood swings, irritability, depression, personality changes. In fact, sometimes the presenting symptom is the behavioral changes, not so much memory. Motor impairments, that's very, very common. What do I mean by that? These are the patients who might come to me. I have a geriatric clinic, so people come with different geriatric syndromes. They might first come to me for falling, frequent falling, or gait and balance problems. They won't even tell me there's a memory problem. And then as we do the assessment, we find that, their scores on memory screening is much lower. They might sometimes have tremors or shaking. Sometimes they have hallucinations, delusions, and urinary incontinence. So you can see that there is an overlap of symptoms between different kinds of dementia. And so getting a good history, asking the family, what are the symptoms that started? I make this analogy. It's like the tributaries of a river. It starts as a tributary, then it goes to a river, and then the river goes into the ocean. So if I see someone with advanced dementia for the first time, they're already in the ocean, then trying to go back and see what started first can be really difficult. So early diagnosis really helps us better with telling what kind of dementia. Again, for the same reason as the dementia progresses, I told you it becomes mixed, more than one etiology, more than one cause. So these are the vascular changes. You see all those white, fluffy, cotton-like abnormalities. So these are the patients where if we say they have vascular dementia, they say, but I never had a stroke. And then a lot of times they have white matter changes. We have to show it. And they have those changes because perhaps they did not control their high blood pressure, because sometimes patients don't like taking medications. And high blood pressure does not necessarily cause symptoms. So mixed dementia. Mixed dementia is where a person may have more than one type of dementia. 50% of people with dementia, almost like half of them, have evidence of more than one cause of the disease in the brain. And the likelihood of having more than one cause, mixed dementia, increases with age, and it's highest in the oldest individuals, 85 or older. In fact, in the Rush Memory and Aging Project, which had 1,000 volunteers in the study, it showed that more than 94% of the participants had at least one known neuropathology. And of those who had at least one neuropathology, 78% had two or more, 58% had three or more causes, and 35% had four or more. And the most common combination was Alzheimer's and vascular dementia. So what is Lewy body dementia? This is a slightly different presentation. Here, the patient comes with typically fluctuating memory loss, where the caregiver will say, some days he's just normal, and then other days I see the changes. There's difficulty with attention, focus, problem solving. There's more confusion, slow processing speed. And they may present with Parkinson-like features, where they might have a tremor, they're very rigid, slow moving, shuffling gait, balance problems, frequent falling. A lot of them have sleep disturbance. They're sleepy, more sleepy during the day. At night, they're acting out in their sleep. So they have what is called REM, rapid eye movement sleep behaviors. So we all have rapid eye movement stage of sleep when we dream, and then we get up, we feel refreshed. Normally, during this stage of sleep, the tone of the muscles is down, like we are dead weight, limp. But in people with REM sleep behaviors, the tone increases. These are the people who are moving out their hands. And in fact, the wives will say, oh yeah, he hits me inadvertently. He's acting out his dreams. Sometimes I've had people fall out of the bed, and I've had people sleepwalking. And then the next day, they don't remember anything. The most salient symptom that immediately makes you think of Lewy body dementia is the vivid visual hallucinations. So these hallucinations are different from the hallucinations in Alzheimer's, and that the patient can describe very vividly. They can tell you, I see every day a little baby. It's got blonde hair, blue eyes. It's wearing a red dress. So they can describe it to the T. And if they have, for example, a hallucination of an animal, they don't get scared. They do not get distressed. That's the difference. And sometimes, even though it looks real to them at the time they have it, later, if you talk to them, when they come to the clinic, for example, and I ask them, do you really think it was real, or you think your brain made it up? These patients will say, I'm not sure. Maybe it was a dream. And they don't get offended with me for asking that question. Whereas in Alzheimer's disease patients, I have to be very careful how I ask because they get really mad. They say, what do you mean? You think I'm crazy or something like that? So these patients have hallucinations that, for the most part, are not distressing. They do have delusions and some paranoia and accompanying depression and anxiety. As I said, it's fluctuating. They have good and bad days. The other thing that's very, very important to remember is they are very sensitive to medications. And sometimes some of these patients, the diagnosis gets unmasked when they are in the hospital. So the patient is in the hospital, they're in a strange environment, they get really confused, and then they might have had an operation or some surgery requiring anesthesia and pain medication. And then, because they are very agitated, they are given antipsychotic medication to calm them down. And that makes them really, really go off the wall when you need to get a sitter. So, if they reacted violently to antipsychotic medication, and they're very sensitive to medications, you have to think of Lewy body dementia. These patients also have changes that go beyond just the brain. They could have changes in their blood pressure and heart rate, where when they stand up, the blood pressure drops, they feel very dizzy and they're falling. Remember that not everybody with Lewy body dementia have all these symptoms, but most of them have the fluctuating memory, the sleep problems, the vivid visual hallucinations. So that's like a marker. And once we diagnose Lewy body dementia, we need to be careful with medications because we know they're sensitive to medications. Then you have the less common frontotemporal dementia patients. These are the patients who come to me and not necessarily with memory problems. Usually it's the spouse complaining of change in personality and behaviors. So they could either be on one side apathetic, lack of motivation, just sitting there, not wanting to do anything. Or it could be the opposite. It could be very impulsive. They lose their filters and they might do things and they might have behaviors that are inappropriate. So these are the people who they are preoccupied with sex, for example. They might be the ones that go to church and they inappropriately want to hug and kiss people during service. Or these are the people coming out of grocery store, and when they are standing with their caregiver at the checkout, the caregiver is trying to pay the money to get out of the store. And I've had a couple of patients where they are so impulsive, they'll just take the candy or whatever is there in the checkout, right? They'll just put it in their pocket and walk out, and then the security catches them. And then I've had to kind of explain to security, give letters to the policeman saying the patient is frontotemporal dementia. They can't help reaching out for things and putting it in their pocket. They neglect personal hygiene. The other thing that can be really sad, I think this is the most difficult type of dementia for the caregiver and for the providers, is because they lose their empathy. I remember once I had a wife who brought the husband for the first time for the new patient consult. And as we were talking, she started crying, saying, he doesn't love me anymore. He has no empathy. Like she was cutting a vegetable and by mistake, she cut the tip of her finger. And you would expect, the husband to get concerned and take her to the ER. And he was like, well, come on, when are you going to finish the dinner? And he was not bothered by the fact that she was bleeding because they have loss of empathy and compassion. And many times it could, make the spouse think of divorce because of the things they are doing, their inappropriate behaviors. Language difficulties. So there's two kinds of frontotemporal dementia. One is the behavioral variant, where I talked about either apathetic, lack of motivation, or the other way, disinhibited and impulsive. So if it's not a behavior variant, it could be a language problem. Here they have difficulty finding words. and it gets worse and worse. Or it could be difficulty with language where they cannot use the correct grammar, their vocabulary decreases, they are no longer able to read or write, they cannot understand instructions. And so communication becomes very difficult. I always say that for every patient I have an invisible second patient, which is the family or the caregiver, because everything falls on the caregiver. So in our clinic, we have social workers, and one of the unique things that we try to do is we spend more time with the family than with the patient sometimes, because it's the caregiver who executes the plan. 83% of help for somebody with Alzheimer's is provided by family and friends. 2/3 of these caregivers are women, and 1 in 3 are above the age of 65. And 1 in 3 dementia caregivers are actually daughters. And 1 in 4 caregivers belong to the sandwich generation, where they are trying to, work to save for their own retirement. They're trying to pay for their teenagers, the children's education. And they're also trying to save money to pay for their parents' caregiving, because we all know that Medicare doesn't cover all of the caregiving costs. So it's a very tough place to be in. So if you look here, it's a slightly older slide with the statistics that in Florida in 2020, the number of caregivers was 527,000. I just want to say that sometimes I'll have caregivers, they don't think of themselves as caregivers. It's like, okay, I'm the wife. They don't say that in any survey that they are the main caregiver. So the number of caregivers might be more than the number quoted here. Look at the total hours of unpaid care and the total value of unpaid care. So 47.8% of these caregivers have chronic health conditions, and 16%, and I think, again, this is an understatement, of caregivers have depression. Let me talk about some of the symptoms that are red flags, and we need to remember this. And this is not only for the person with the cognitive problem, but also the caregiver. So if an older adult has persistent, vague, unexplained physical complaint, that's a red flag, because these are the people, for example, they might have abdominal pain or palpitations. They go to the ER multiple times, and every time they go, they rule out a heart attack, or they, just give them IV fluids or something for constipation. They don't know what the problem is, but they keep complaining about the same problem. You need to keep an eye on these people. If they complain of memory loss and decreased ability to focus or concentrate, they're always tired, they have social withdrawal, they're no longer wanting to go to church, no longer participating in a hobby, and they're saying that they're not sleeping. If you have most of these symptoms together, you need to think of depression, because the presentation of depression in an older adult is not very typical. Typically, when we think of depression, you're thinking of someone who's sad, crying, and saying that they're depressed. No, most of my older patients and caregivers, they don't like the word depression. It has a negative connotation, and they might say they're not depressed, but they might have all these what we call somatic complaints, which is actually a presentation of depression. So why should we heed these warning signs? Because we need to know that just like memory loss, depression is not a normal part of aging. And if there is new onset of depression in an older adult, it doubles the risk of dementia. So it needs to be recognized and treated. And if there is depression which is not treated, it increases other health risks. For example, it increases the chance of heart attack by 30%. And if you look at the most common cause for elder suicide, it's untreated depression. Then we talk about the risk factors for dementia. So I always say the top 3 risk factors for dementia is increased age, and increased age. Because if you look at 65-year-olds, 1 in 10 might have Alzheimer's, and then it doubles every 5 years above the age of 65. And as I said, most of my patients, because we are living longer, they're above the age of 80, so their chance of having dementia is much higher. Physical inactivity is a big risk factor. High blood pressure, diabetes, obesity, smoking, excessive alcohol consumption, high cholesterol. So all of these things other than age, we have control over it. Poor sleep can be a risk factor. Any head injury. That's why I tell my 80-year-olds, please, if you want your gutters to be cleaned or you want to paint, you want to go to the top of the roof, get somebody else to do it. You should not be doing it. You want to protect your head. Depression and social isolation is a risk factor. Hearing loss, that's a very big thing. So, hearing loss is an independent risk factor for dementia. A lot of people don't want to get their hearing addressed. And I know that many times they'll complain that the spouse is the cause because they are mumbling. The spouse of the person with hearing loss will say the TV is so loud. But then once I explain to them that you need to get hearing addressed, so what I say is, as I told you, there's a memory area, one on the right, one on the left. If you have hearing loss and you don't address it, some of the memory cells in the memory area of the brain is getting recruited by the hearing area. And you can't afford to be, loaning your memory cells. As it is, you're losing memory cells as we get older. We want our memory cells to work efficiently on memory. And so getting the hearing loss addressed, wearing a hearing aid is really going to help your memory and your cognition. So the factors that we talked about so far are all modifiable. What are the non-modifiable factors? Family history. So if somebody has a first-degree relative or more than one first-degree relative with Alzheimer's, their chances of having Alzheimer's, the risk is much higher. So genetics and then age-related changes in the brain. These are non-modifiable risk factors. So the reversible causes of dementia, when somebody comes with memory loss and we do a memory screening and find that the memory scores are low, we always look for things that we can fix. So many times medications, my patients are on medications that can interfere with memory. These include sleeping pills. It could either be over the counter, all the PM pills, Tylenol PM, Advil PM. The PM component decreases the memory chemical in the brain. Anticholinergics. Anticholinergics are all these medications which decrease the memory chemical in the brain. These include the medications for bladder incontinence, the older medications for bladder incontinence, again, the sleep medications. It could be some of the older antidepressants, pain relievers. Then most of my patients are living alone and they're not cooking for one or two people. They're mainly eating outside or they're eating TV dinners, which are not really very nutritious. So they have nutritional deficiencies like vitamin B12, folate, thiamine, etc. We talked already about obstructive sleep apnea. Low thyroid can cause everything to slow down, including the brain, the memory, and the thinking. So that can be something which can be fixed. A simple blood test, and if the thyroid is not functioning well, we can replace it. Normal pressure hydrocephalus. That's a rare condition. What that means, normal pressure hydrocephalus, hydro is water, cephalus in the brain, too much water in the brain. So these patients usually present with difficulty walking. They have some urinary incontinence and some memory loss. This is a treatable condition. So we do a brain scan, and if we find that the brain scan shows too much of the fluid, the neurosurgeon sees them and they have to drill a hole in the skull and put a shunt, a tube, which takes the fluid and diverts it. And this is, again, a very rare condition, but it's something that's reversible. Alcohol abuse. Alcohol can cause dementia if taken in huge quantities. And it's important that right now, I usually tell patients that as they get older, their body doesn't metabolize alcohol well, and to drink in moderation and avoid drinking, switch to non-alcoholic if possible, because a lot of my patients are on medications that interfere with alcohol. Depression and anxiety sometimes can masquerade as dementia and they can be treated. Not all causes that we talked about now are reversible completely 100%. However, identifying and treating these reversible causes would definitely improve the cognitive function and prevent further decline in most people. So why are we talking about Alzheimer's dementia? It's because of the prevalence. 1 in 9, more than 65, 10% have Alzheimer's. 2/3 of Americans with Alzheimer's disease are women. And older Black African Americans are twice at risk. And older Hispanics are 1.5 times more at risk. So high-risk populations, we need to do more programs to include them in our studies. as well as decrease barriers and be culturally sensitive. So, what are the stages of dementia? So, if you talk about theoretically, the 7 stages of dementia are: stage 1 is no cognitive decline, 2 is very mild cognitive, 3 is mild cognitive decline, 4 is moderate, 5 is moderately severe, 6 is severe, 7 is very severe. So, in real life, when we try to say stages of dementia, we try to make it a little bit more simplified. So, in my own practice, it's easier to just call it mild, moderate, advanced. And how do we say somebody has mild dementia? If they have mild memory lapses, like word finding difficulties, it becomes moderate when they start having more confusion, personality changes, and they are having more and more need for assistance. So these are the patients who perhaps need reminders to have a shower. If you don't remind them, they might wear the same clothes for 3, 4 days and they may not change. They may need more assistance with their day-to-day activities. Advanced dementia is when the memory lapses are more severe. They are no longer able to recognize close family members. Their language skills are declining. They also lose physical abilities. And this could include not knowing what to do inside the bathroom, not knowing how to get into the car, or not knowing how to get into the bathtub, or not knowing what to do inside the bathtub. They have then difficulty in swallowing because the brain is not telling them what to do. So if you give them medicines, they do what is called pocketing, which is keeping it in the mouth and not knowing what to do. And you may have to say swallow. And then they'll look at you as like, what does it mean, right? So that is advanced dementia. And if you look at the most common cause of death in dementia, it's aspiration, where food goes down the windpipe instead of the food pipe, causing pneumonia. So how do you assemble a healthcare team? So either, you establish with a geriatrician or a neurologist who specializes in memory loss. If you have a local dementia care program, connect with them. Really, the team is best if it has a social worker, a speech therapist, or access to a physical therapist, occupational therapist, and of course, you should have a PCP who coordinates the care. So this is meant if it's a person who's working, who's been diagnosed with dementia. I think it's important for them to consult their human resources department or the employee assistance program to talk about family leave, disability benefits, and other employee benefits. If there's problems with the cognition interfering with job performance, you could either reduce your hours or switch to a less demanding position, or worst comes worst, apply for disability income. For those who are veterans, they need to connect to the VA for veterans benefits. And the Social Security also has a compassionate allowance program, which may help with speeding up a disability claim because this is overwhelming for people to go through. And so it's good to be connected to a team that has a social worker who can help you connect to the resources. If you're living alone, it's very important to find someone reliable who is a caregiver who can visit you frequently, be an emergency contact, and come with you to doctors' offices to give history. Remember, people with Alzheimer's and other dementias are at a greater risk of falling, so they should consider getting an emergency response system, either like a watch, a smartwatch, which detects falls, or one of those pendants you can push saying, I've fallen, I cannot get up. Contact an occupational therapist who can teach you ways to stay independent, like, making sure that you have a raised toilet seat, grab bars in the bathroom, removing all the fall risks from the home. Make sure you assign a healthcare surrogate and complete the HIPAA form so that if somebody calls asking about your health, they have the authorization from you that the records can be released. So what are the treatment options? The newer treatment options are the disease-modifying anti-amyloid therapy. Then these medications are infusions, lecanemab and donanemab. They clear the amyloid plaques. The amyloid is the abnormal protein, which is thought to cause Alzheimer's. It modestly slowed down the progression of cognitive and functional decline, but they do have side effects, which are called ARIA, amyloid-related imaging abnormalities. When you do the brain scan in people receiving infusions, some of them had brain bleeds, micro hemorrhages, and brain swelling, which caused them to stop having the infusion and monitoring and frequent brain scans. So, in the studies, it was very modest effect, which was statistically significant. But when you look at the actual delay in cognitive decline, it was quite small. It does not stop the disease, cure, or reverse Alzheimer's yet, but it offers great promise because now they're coming up with studies which are trying to minimize these side effects. And currently available medications do come with high cost and it's labor intensive, requires a reliable informant to take them for the infusions and to go for frequent imaging. The medications that are available orally are the donepezil, also known as Aricept, rivastigmine, known as Exelon, galantamine, and memantine, which is Namenda. These are not cures, but they perhaps have a modest effect in slowing down the progression, help delay the behavioral challenges, which helps people remain in their own home and delay institutionalization. So if somebody wants to stay home or, in order to make sure that they are independent and safe, I think using technology is great, like using door alarms, safety lighting, personal emergency response system that detects faults. Important to know about what the transportation resources are if somebody should stop driving, having a medical ID or bracelet. So if they are walking and they fall and a stranger or a good Samaritan sees them, they know who to contact. So think about use of technology to keep people in their own home. Lifestyle modification, brain healthy diet is important, avoiding highly processed food, continuing to move and be physically active, cognitive stimulation, doing puzzles, reading, taking up a new hobby, socialization, and stress management and making sure they have good sleep are all good things for the brain. So what are the aids that you can use? So using reminders, a pill box to organize medications, automated pill dispensers are now available with alarms to keep track. Asking family members or friends or find local services to help. So a lot of times, having aid coming twice a week to cook, getting a case manager to help paying bills, transportation or shopping helps. We talked about the technology. Make sure you schedule regular appointments with primary care physician and arrange for someone to come with you for medical appointments so that they can give a history and remember what the doctor is saying in terms of recommendations. Connect with local support groups. It's very important to talk about legal and financial planning to make sure you have a living will, a power of attorney for finances, and a healthcare proxy. Talk about DNR, have the yellow do not resuscitate forms completed. So review the financial resources and plan for long-term care needs. A support group really helps because you see other people walking in the same shoes and the resources that they have used. Make sure you find respite for the caregiver. And here, the local resources in our county are the Caregiver Cafe, and we have the Dementia Live program, which really helps educate caregivers what it's like to live in the shoes of someone with cognitive impairment. So here in Brevard County, we have the Center for Family Caregivers, which is a Health First Foundation donated resource where we do a variety of support groups and activities free for caregivers. And then knowing the local transportation options is good because before I tell someone to stop driving, our social worker gives them the alternate transportation resources. So these are the resources. This concludes my presentation and I'm open for any questions.
Thank you, Dr. Visa. I hope the people can just put in the chat what question you have, or you can turn on your mic and you can ask a question to Dr. Visa.
Okay, so I see someone asking, what is the group that can help with SSA Medicare claims? So usually if the person is a veteran, the VA social workers really help with that. If not, if the person is homebound, you can ask the primary care physician to refer to the home care team. And all insurances have home care teams that have a social worker that can guide you as to how to navigate the system. So BADLS is Basic Activities of Daily Living. So basic activities of daily living are transferring, bathing, grooming, toileting, and eating. Why is that important? Is because for people who have long-term care insurance, many times in order for long-term care insurance to say that they will kick in and cover services, the person should have, deficits in at least two of those. So many times that's the problem that we run into, because the person with dementia can still eat, but they need the meals to be provided. They can still shower, but somebody needs to be on their case, like, keep reminding them 2-3 times. So that's why we always write about the basic activities of daily living in our documentation to help these people identify early when they are no longer able to keep up with their basic activities of daily living so that long-term care insurance can kick in.
Can you hear me?
Yes.
I facilitate a group for ADRC for recently diagnosed people. And one of the questions that often arises is about whether they would be seeking care from a neurologist or a geriatrician. And I just wondered, Dr. Visa, if you would chat a little bit about the different specialties, what they are best at, and what your advice is in that regard.
There are many times that the neurologist refers their patients to us. So the difference is, it depends on the kind of setting. But if you look at most neurology offices, they don't have a social worker. So from the geriatric practice, we look at the big picture. As I told you, for every patient I have a second invisible patient who's the caregiver. And because I have a social worker, we look at the picture and we hold the hand of the caregiver as they navigate the journey. So that's the difference. The other difference that I'll say is, dementia is not something where you just need a treatment. I mean, it's more management, right? So in our geriatric practice, what is different is that the time we spend, like my new patient visits are an hour, my return patient visits are half an hour. Every patient gets to see the social worker. Every 6 months, we do what is called a care plan visit. So during the care plan visit, which is a 1-hour visit, we basically have the caregivers complete a form that includes a stress thermometer as to where their stress level is. And so if the stress level is high, we then focus on what are the stressors. And many times it's lack of respite, their own medical situation, complex family dynamics, psychosocial stressors. So we do what is called, we identify the social determinants, see what the barriers are. Is finance a barrier? Future planning. So addressing those are really important because it determines the outcome. The other thing is, in a geriatric practice, we do what we call having the difficult conversations. So when should someone stop driving? Who is going to tell the person they should stop driving? More importantly, if they stop driving, who's going to take them around? Who is going to tell someone, that you need to have one spokesperson for the family? Because many times, you have a daughter staying with somebody with dementia taking care, and the sister living in California telling what to do or what this daughter is not doing right. But the other sister comes once a year. We see those kind of stories. So it's never a one size fits all. Having a social worker makes such a big difference. And then completing all the paperwork. That's something that, completing the 1823, if somebody's going to assisted living, completing the long-term care, we get a lot of requests for sparing them of jury duty, doing the disabled permit, parking permit, completing FMLA forms, because, the daughter or the son needs the FMLA forms completed so that they can help their loved one. So the other thing which is different in geriatrics is we look at the function of the person. We don't just look at the memory. A neurologist looks at the brain. We look at the person. Two different things. A lot of people are taking so many medications. Do they really need those medications? We're talking about home safety, what kind of technology they can use to remain at home. And we do family conferences where we bring all the family together and keep them on the same page. Yeah, I just want to complete by saying that neurology or geriatrician, as long as, you have a team that really is able to meet your needs, it's really good. We don't have as many geriatricians as is needed, or kind of not that many in number. So I feel that connecting with the right team that provides the services and partnering, it takes a village to take care. of an older person with dementia.
Very good. Thank you very much.
Thank you. Thank you all. And thank you for inviting us. And hopefully we can partner to spread the word more.